Welcome to the video lecture for Unit 3, Module 7.1. In this one, we're going to talk about some of the components of the respiratory system as well as get into the upper respiratory tract. As always, here are your learning objectives. Be sure to utilize these when you're studying for both the lecture quiz as well as the exam. All right, to get started. So when we think of the respiratory system, we generally think of breathing, pulling air into and out of our bodies. However, an efficient respiratory system must do more than merely move air. Cells need energy for maintenance, growth, defense, and division. Our cells obtain that energy mainly through aerobic mechanisms that require oxygen and produce carbon dioxide. Many aquatic organisms can obtain oxygen and excrete carbon dioxide by diffusion across the surface of their skin or specialized structures such as the gills of a fish, but such arrangements are poorly suited for life on the land. The exchange surfaces must be very thin to permit rapid diffusion. In air, these exposed membranes collapse, evaporation and dehydration reduce blood volume, and the delicate surfaces become vulnerable to attack by pathogens. The respiratory exchange surfaces of humans are just as thin and delicate as those of aquatic organisms, but they're confined to the insides of the lungs, which are a warm, moist, protective environment. Under these conditions, diffusion can take place between the air and the blood. The cardiovascular system is the link between your interstitial fluid and the exchange surfaces of your lungs. Circulating blood carries oxygen from the lungs to peripheral tissues. Your blood also accepts and transports the carbon dioxide generated by those tissues, delivering it to the lungs. So in this module, we'll describe how air enters the lungs as a result of the actions of the respiratory muscles and how oxygen and carbon dioxide are exchanged across delicate epithelial surfaces within the lungs. The respiratory system is composed of structures involved in ventilation, or providing air, and gas exchange. In this section, we're going to consider the body's systems, functions, and structural organizations. Let's talk about some of the functions of the respiratory system. So the respiratory system has 5 basic functions. 1, providing an extensive surface area for gas exchange between the air and circulating blood. 2, moving air to and from the gas exchange surfaces of the lungs along the respiratory passageways. 3, protecting respiratory surfaces from dehydration, temperature change, or other environmental variations, and defending the respiratory system and other tissues from invasion by pathogens. 4, producing sound for speaking, singing, and other forms of communication. And 5, facilitating the detection of odors by olfactory receptors in the superior portions of the nasal cavity. In addition, the capillaries of the lungs indirectly help to regulate blood volume and blood pressure, and they do so by the conversion of angiotensin 1 to angiotensin 2. We can organize the respiratory system from either an anatomical or a functional perspective. Anatomically, we can divide the system into an upper respiratory system and a lower respiratory system. The upper respiratory system consists of the nose, the nasal cavity, the paranasal sinuses, and the pharynx, or the throat. These passageways filter warm and humidify incoming air, protecting the more delicate surfaces of the lower respiratory system. They also reabsorb heat and water from outgoing air. The lower respiratory system includes the larynx, or the voice box, the trachea, or the windpipe, the bronchi, the bronchioles, and the alveoli of the lungs. The term respiratory tract refers to the passageways that carry air to and from the exchange surface of the lungs. The conducting portions of the respiratory tract begin at the entrance to the nasal cavity and extend to the pharynx, larynx, trachea, bronchi, and larger bronchioles. The respiratory portion of the tract includes the smallest, thinnest bronchioles and the associated alveoli, which are the air-filled pockets within the lungs where all gas exchange between air and blood takes place. Gas exchange can take place quickly and efficiently because the distance between the blood and the alveolar capillary and the air inside the alveolus is generally less than 1 meter. In some cases, this distance is as short as 0.1 meters. To meet the metabolic requirements of peripheral tissues, the surface area for gas exchange in the lungs must be very large. It's about 35 times the surface area of your body. Estimates of the surface area involved in gas exchange range from about 70 meters squared to about 140 meters squared, or about 730 feet to about 1,506 feet or so. Filtering, warming, and humidifying inhaled air begin at the entrance to the respiratory tract and continue as air passes along the conducting portion. By the time air reaches the alveoli, most foreign particles and pathogens have been removed, and the humidity and temperature are within acceptable limits. The success of this conditioning process is due to the respiratory mucosa. The respiratory mucosa lines the conducting portion of the respiratory system. A mucosa is a mucous membrane, one of the 4 types of membranes introduced in 168. It consists of an epithelium and an underlying layer of areolar tissue. The lamina propria is the underlying layer of areolar tissue that supports the respiratory epithelium. In the upper respiratory system, the trachea and the bronchi, the lamina propria contains mucus glands that discharge their secretions into the epithelial surface. The lamina propria in the conducting portion of the lower respiratory system contains bundles of smooth muscle cells. At the bronchioles, the smooth muscle cells form thick bands that encircle or spiral around the lumen. The structure of the respiratory epithelium changes along the respiratory tract. A pseudostratified ciliated columnar epithelium with numerous mucus cells lines the nasal cavity and the superior portion of the pharynx. The epithelium lining inferior portion of the pharynx is a stratified squamous epithelium similar to that of the oral cavity. These portions of the pharynx conduct air into the larynx and also convey food to the esophagus. The pharyngeal epithelium must therefore protect against abrasion and chemical attack. A pseudostratified ciliated columnar epithelium, comparable to that of the nasal cavity, lines the superior portion of the lower respiratory system. The smaller bronchioles have a cuboidal epithelium with scattered cilia. The exchange surfaces of the alveoli are lined by a very delicate simple squamous epithelium. Other, more specialized cells are scattered among the squamous cells, and together they form the alveolar epithelium. Debris and/or pathogens in inhaled air can severely damage the delicate exchange surface of the respiratory system. A series of filtration mechanisms that make up the respiratory defense system prevent such contamination. Along much of the respiratory tract, mucus cells in the epithelium and mucosal glands in the lamina propria produce a sticky mucus that bathes exposed surfaces. In the nasal cavity, cilia sweep that mucus and any trapped debris or microorganisms towards the pharynx. There it is swallowed and exposed to the acids and enzymes of the stomach. In the lower respiratory system, the cilia beat towards the pharynx, moving a carpet of mucus in that direction and cleaning the respiratory surfaces. This process is often called a mucus escalator. Filtration in the nasal cavity removes virtually all particles larger than about 10 microns from the inhaled air. Smaller particles may be trapped by the mucus of the nasopharynx or by secretion to the pharynx. The rate of mucus production in the nasal cavity and paranasal sinuses speeds up upon exposure to unpleasant stimuli, such as noxious vapors, large quantities of dust and debris, allergens, or pathogens. The familiar signs and symptoms of the common cold appear when any of more than 200 types of viruses invade the local respiratory and epithelium. Most particles, 1 to 5 microns in diameter, are trapped in the mucus coating of the respiratory bronchioles or in the liquid covering the alveolar surfaces. These areas are outside of the mucus escalator, but the foreign particles can be engulfed by alveolar macrophages. Most particles smaller than about 0.5 microns remain suspended in the air. I just want to give a quick breakdown of the respiratory defense system. So large quantities of airborne particles may overload the respiratory defenses and produce a variety of illnesses. For example, irritants in the lining of the conducting passageways can provoke the formation of mucus plugs that block airflow and reduce pulmonary function. Damage to the epithelium in the infected area may allow irritants to enter the surrounding tissues of the lungs. The irritants then produce local inflammation. Airborne irritants, such as those in cigarette smoke, are known to promote the development of lung cancer. Aggressive pathogens can also overwhelm respiratory defenses. Tuberculosis, or TB, results from an infection of the lungs by the bacterium Mycobacterium tuberculosis. Other organs may be invaded as well. Bacteria may colonize the respiratory passageways, the interstitial spaces, the alveoli, or a combination of the three. Signs and symptoms are variable. They generally include coughing and chest pain, plus fever, night sweats, fatigue, and weight loss. In the 1900s, TB, then known as consumption, was the leading cause of death. It remains among the most common and serious infectious diseases. An estimated 1/3 of the world's population is infected with TB. According to the CDC, there are nearly 2 million TB-related deaths worldwide each year. The respiratory defense system can also fail due to inherited congenital defects affecting mucus production or transport. For example, cystic fibrosis is the most common lethal inherited disease in individuals of Northern European descent. It occurs in one birth in about 2,500. The respiratory mucosa in these individuals produces dense, viscous mucus that cannot be transported by the respiratory defense system. The mucus escalator stops working, and this leads to frequent infections. Mucus also blocks the smaller respiratory passageways, making breathing difficult. For people who have CF and live in the United States, the median predicted age of survival is the mid-30s. Death generally results from heart failure associated with massive chronic bacterial infections of the lungs. The nose is the primary passageway for air entering the respiratory system. Air normally enters through the paired external nares, or nostrils, which open into the nasal cavity. The nasal vestibule is the space contained within the flexible tissues of the nose. The epithelium of the vestibule contains coarse hairs that extend across the external nares. Large airborne particles such as sand, sawdust, or even insects are trapped in these hairs and prevented from entering the nasal cavity. The nasal septum divides the nasal cavity into the left and right portions. The bony portion of the nasal septum is formed by the fusion of the perpendicular plate of the ethmoid bone and the plate of the vomer. The anterior portion of the nasal septum is formed of hyaline cartilage. This cartilaginous plate supports the dorsum nasi, or bridge, and the apex, or the tip of the nose. The maxillary, nasal, frontal, ethmoid, and sphenoid bones form the lateral and superior walls of the nasal cavity. The mucus secretions produced in the paranasal sinuses, or the sinuses of the front, sphenoid, ethmoid, and paired maxillary and palatine bones, help to keep the surfaces of the nasal cavity moist and clean. The tears draining through the nasolacrimal ducts do so as well. The olfactory region is the superior portion of the nasal cavity. It includes the areas lined by the olfactory epithelium. 1, the surface or the interior surface of the cribriform plate, 2, the superior portion of the nasal septum, and 3, the superior nasal conchae. Receptors in the olfactory epithelium provide your sense of smell. The superior, middle, and inferior nasal conchae project towards the nasal septum from the lateral walls of the nasal cavity. Some references might use the term superior, middle, and inferior turbinates if you're reading some outside literature. To pass from the vestibule to the internal nares, air tends to flow between the adjacent conchae through the superior, middle, and inferior meatices. These are narrow grooves rather than open passageways. The incoming air bounces off the conchal surface and churns like a stream flowing over rocks. The turbulence serves as several purposes. As the air swirls, small airborne particles are likely to become in contact with the mucus that coats the lining of the nasal cavity. In addition, the turbulence provides extra time for warming and humidifying incoming air. It also creates circular air currents that bring olfactory stimuli to the olfactory receptors. The bony hard palate is made up of portions of the maxillary and palatine bones. The hard palate forms the floor of the nasal cavity and separates it from the oral cavity. A fleshy soft palate extends posterior to the hard palate, making the boundary between the superior nasal pharynx and the rest of the pharynx. The nasal cavity opens into the nasal pharynx through the connection known as the internal nares. The mucosa of the nasal cavity prepares inhaled air for arrival at the lower respiratory system. Throughout much of the nasal cavity, the lamina propria contains an abundance of arteries, veins, and capillaries that bring nutrients and water to the secretory cells. The lamina propria of the nasal conchae also contains an extensive network of highly expandable veins. This vascularization warms and humidifies the incoming air, and cools and humidifies the outgoing air as well. As cool, dry air passes inward over the exposed surfaces of the nasal cavity, the warm epithelium radiates heat and water into the mucus evaporates. In this way, air moving from your nasal cavity to your lungs is heated almost to body temperature. It is also nearly saturated with water vapor. These changes protect more delicate respiratory surfaces from chilling or drying out, two potentially disastrous events. If you breathe through your mouth, you eliminate much of this preliminary filtration, heating, and humidifying of the inhaled air. To avoid alveolar damage, patients breathing on a respirator or a mechanical ventilator, which utilizes a tube to conduct air directly into the trachea, must receive air that has been extremely filtered and humidified. As air moves out of the respiratory tract, it again passes over the epithelium of the nasal cavity. This air is warmer and more humid than the air that enters. It warms the nasal mucosa, and moisture condenses on the epithelial surfaces. In this way, breathing through your nose helps prevent heat loss and water loss. The extensive vascularization of the nasal cavity and the vulnerable positions of the nose make a nosebleed, or epistaxis, a fairly common event. The leading cause of epistaxis in children is nose picking. This bleeding generally involves the vessels of the mucosa covering the cartilaginous portion of the septum. Possible causes include trauma, such as a punch in the nose, drying out, infections, allergies, or clotting disorders. Hypertension can also bring on a nosebleed by rupturing small vessels of the lamina propria. The pharynx, or the throat, is a chamber shared by the digestive and respiratory systems. It extends between the internal nares of the entrances to the larynx and the esophagus. The curving superior and posterior walls of the pharynx are closely bound to the axial skeleton, but the lateral walls are flexible and muscular. We can divide the pharynx into the nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx is the superior portion of the pharynx. It's connected to the posterior portion of the nasal cavity through the internal nares. The soft palate separates it from the oral cavity. The nasopharynx is lined by the same pseudostratified ciliated columnar epithelium as the nasal cavity. The pharyngeal tonsil is located on the posterior wall of the nasopharynx. Each auditory tube opens into the nasopharynx at the nasopharyngeal meatus or on either side of the tonsil. The oropharynx extends between the soft palate and the base of the tongue at the level of the hyoid bone. The posterior portion of the oral cavity communicates directly with the oropharynx, as does the posterior inferior portion of the nasopharynx. At the boundary between the nasopharynx and the oropharynx, the epithelium changes from pseudostratified columnar epithelium to stratified squamous epithelium. The narrow laryngopharynx is the inferior part of the pharynx. It includes that portion of the pharynx between the hyoid bone and the entrance to the larynx and esophagus. Like the oropharynx, the laryngopharynx is lined with a stratified squamous epithelium that resists abrasion, chemical attack, and invasion by pathogens.